regarding the data of locomotion and mammoth study, the triple class relapsed refractory multiple myeloma patients represented an unmet medical need because there are not a standard of care for these patients, and their overall survival is not superior to 9 months. In this scenario, BCMA appears to directly attack the plasma cell with anti-drug conjugated antibody and bispecific monoclonal antibodies and CAR-Ts. And in our country, in Spain, the access to this therapy is inside in clinical trials. Based on this rationale, Salamanca, the Hospital of Salamanca, decided to design an exploratory study to indirectly compare the overall response, the efficacy, as well as the safety profile, the time to access, and the time of hospitalization of these patients. We have 63 patients treated with this therapy, with 34 with CAR-T and 29 with bispecific monoclonal antibodies. There are some significant difference between both groups. For example, bispecific monoclonal antibodies group, they are heavily pretreated patients with a median of prior lines of 4. 100% of these patients is triple exposed, and 70% triple class refractory patients. In contrast, the CAR-T group, this patient, the median prior lines of therapy was 2. 70% of these patients were triple exposed class patients, and no difference between triple class refractory patients between bispecific monoclonal antibodies group and CAR-T group. We notice some difference between the time to access to this therapy between groups. For example, median time to treat this patient with bispecific monoclonal antibodies was 12 days, and with CAR-T was 60 days. In addition, the time to hospitalization with this therapy was different too. For example, patients treated with bispecific monoclonal antibodies were hospitalized 10 days, and with CAR-T 21 days. And this difference were because the safety profile. Regarding the efficacy, the overall rate response at early assessment of the disease was different between both groups. In the case of CAR-T group, the overall rate response at 30 days after therapy was over 90% and near to 50% in the case of the bispecific monoclonal antibodies group. It's important to mention that near to 30% of patients treated with CAR-T achieved at least complete response after 1 month of the therapy. In contrast, only 10% of patients treated with bispecific monoclonal antibodies in our study. However, the response getting deeper during the follow-up. For example, patients treated with CAR-T when achieved 67% of patients treated with CAR-T achieved at least complete response at any moment of the follow-up. In contrast, only 50% of patients treated with bispecific monoclonal antibodies. Regarding safety profile, the most frequent adverse events was cytokine releasing syndrome, which was more frequent in the CAR-T group. ICANS, as well-known neurotoxicity, was a very infrequent complication, and we have to pay attention when we treated this patient with CAR-T or bispecific monoclonal antibodies to cytopenias, for example, grade 4 or grade 3 neutropenia or thrombopenia were a very frequent complication and significantly higher in the CAR-T group. However, despite this significant difference between cytopenias between both groups, the rate of infections was more frequent in the bispecific monoclonal antibodies group, especially viral respiratory tract infections. And to conclude, we have to say that also CAR-T and bispecific monoclonal antibodies improve the survival of our relapsed refractory multiple myeloma patients. The overall rate response and survival was better in the case of CAR-T group, with a progression-free survival of 19 months in the case of CAR-T and 66.1 months in the case of bispecific monoclonal antibodies group. And regarding to overall survival, was not reached in the case of CAR-T, and 25.5 months in the case of bispecific monoclonal antibodies group. And finally, we have to corroborate this data with more patients and longer follow-up.